Today I'll discuss my favorite book in orthopedics outside the McKenzie method or MDT 5 textbooks, of course. And that is a book I've talked about before. I've done 2 or 3 small videos on them, on this book. I think they're on Instagram, maybe they're on YouTube, I'm not quite sure. Orthopedic Physical Examination Tests by Cook and Hegedus. This is the 2nd edition, I believe from 2013. The first edition I think was 2008 or 9. I'm pretty sure there's no more current edition. So this is already 13 years old. And what I've talked about before, I will repeat. This book looks at the evidence for tests that we use in orthopedics to diagnose musculoskeletal or orthopedic disorders. It is focused primarily on OSTs or orthopedic special tests. Those are the types of tests that if you've been a patient and you've had a clinician do a quick test on you that takes a few seconds, it's typically an OST. We learn them and have to memorize them in school. I remember the tests where we had to do the manual test where you go around and draw a card and you'd have to do the Veris test or the pivot shift test or any instability test. And you know, I always had a cheat sheet kind of in my office if I needed to do one of those tests and I couldn't remember the exact way to perform it. This also talks about kind of imaging and fracture tests and cluster tests, but the main focus is OSTs. So let's talk briefly about why it's really relevant. It's because it debunks that there's a lot of evidence for these tests that we were taught in school and that clinicians overwhelmingly rely on today to make their diagnoses. So they go through, for example, each page is 1 or 2 tests. The authors, Cook and Hegedus, go through the studies that test is based on. They look at the reliability, sensitivity, specificity, likelihood ratio, and they give it a score of bias. And then they as a composite, they give it what they call a utility score, meaning is there strong evidence to use this test as a clinician? Is there poor evidence? Strongest evidence gives for them is a score of 1. And then if there's not enough evidence to even make a discernment, they give it a score of a question mark. They're like, there's not enough for us to base this decision off of. This is I think every clinician should have this book. You can find it online these days for about $25 used. I buy almost all my books used if I can. Patients, this is also important too, because if you want to see if the clinician is using something relevant for you that has evidence behind it, you can look at this. Now, are there probably some updates in the last 13 years? Yes, and I'll talk about how I think repeated movement testing would probably, hopefully by now, have more research to support its more widespread use in musculoskeletal practice. Unfortunately, in this edition, the lumbar spine chapter is the only chapter that includes repeated movement testing, in this text. That doesn't necessarily mean to me they didn't look at it for the neck, but they probably did not. So let's talk, before I go on to the lumbar spine, people should know this text and use it as clinicians and patients. It's just really, really eye-opening to see all these tests that we were taught were based on shoddy evidence. Not all. I think ligament tests, especially if there's a ligament that's lost its integrity, like the ACL, those tests, hold a lot of evidence, they hold a lot of strength. And you can see why, right? If I move the knee and it goes, well, there's a really strong chance it's because the ligament that's supposed to prevent it from going is not structurally competent anymore. Same with the ankle or the upper neck. Let's move on to the lumbar spine. There are 32 tests that the authors investigate to get a score of strong evidence. 1 on page 298 is the prone isometric chest raise test. I have never used this test. It seemed quite vague in terms of its goal is to ascertain if the patient's low back complaints are musculoskeletal in nature. The next page, page 299, under tests for discogenic symptoms, Centralization gets a score of 1. So of the 32 lumbar tests, those two get a score of 1 for strong support. Now, what's fascinating to me is it's called like a centralization test. It's based on the studies by Laslett and Donaldson. Donaldson wrote a great book. I'm drawing a blank on the name right now. I can put it in the notes, but it's about lumbar spine testing. Or I think it's called rapidly reversible low back pain. I've read it a couple times. It's more evidence-based than for the average patient, so it's more clinical, but it's also a superb, relatively short read. However, nothing in this half of the page says Robin McKenzie invented this test, which I find kind of interesting. It's talking about discogenic symptoms, and that is a sliver of how important repeated movement testing is for the low back. It's not, in my book, just strongly supported when it comes to centralization and looking for symptoms that are referred from discs into the lower extremities, centralizing to the spine when this test is performed correctly. I, of course, use this test also for low back pain or just knee pain, things that are not necessarily discogenic in nature. So I think this is a small subset of how we actually use repeated movement testing in the clinic. Now, to my earlier point, this is just the lumbar spine that there's evidence that they think is strongly supportive. I, of course, use repeated movement testing for centralization in the neck and in the thoracic spine. And I use repeated movement testing in the neck and in the thoracic spine for local neck and thoracic pain and for symptoms that seem like they're possibly coming from a mechanical disorder in the spine. And I'm not necessarily looking for centralization. So I've had patients, come to me, and this is a good resource for me, especially since, as I just mentioned, I will find a lot of knee pain resolves with mechanically fixing the low back. As I've written before, I kind of break it down 3 different ways. The spinal joints can refer symptoms. In the neck, they're called the Cloward signs. In the low back, to my knowledge, there is not a term for this, although there is a seminal study, I believe by Kuslich et al., that looked at where discs can refer pain if they are touched with a probe. A lot of it is buttock, thigh, etc. So we know spines can refer symptoms. Secondly, we know if there is nerve root irritation at the level of the spine, there can be what we call radicular symptoms or radicular signs. Those, unlike referred symptoms, which can be kind of deep, achy, more vague in distribution, they're going to be the small subset of people, this is not the majority of people with spinal disorders. These are the people where it feels like their arm is on fire, it feels like there's a line of nerve pain going down their leg, and they call it sciatica. Radicular symptoms are a small subset, but they are pretty obvious when you see them. The third bucket in my mind, and this is harder to kind of explain to people or get people on board with, is that mechanical problems in one joint, in this example, the spine, can cause problems in other joints, and the pain is therefore manifested in the other joint. This I cannot wrap my head around exactly anatomically or physiologically, but I've seen it enough times to know that people can have knee pain, and if you do a low back maneuver, mind you, the low back is presenting with symptoms, or not necessarily symptoms, signs when we do the examination, which makes this avenue of inquiry appropriate. But if you fix that low back mechanically, the knee pain goes away. And so I think of that as that third group where something's not moving well, and then therefore probably the knee is not moving well when you're doing the activity that's provocative. Maybe it's running, and therefore that knee starts to hurt. But again, I don't have the best explanation. I also don't have the best explanation why mechanical problems in the low back can present with knees that have lost range of motion, where the fix is clearly moving the low back and the knee gains its range of motion, where we haven't made it fuzzy by having the knee move as well. So if we think about those 3 different situations, mechanical problems elsewhere, can also be in the extremities, can also be fixed by fixing the spine mechanically. So I've had patients, for example, I remember one younger gentleman came to me, he had knee pain. I spoke to him, he said his MD orthopedic specialist said it was a chondral problem in the patellofemoral joint. And when I have time, I probe a little bit, and I'm asking kind of what happened in that visit, because I want to know what the patient's been told or taught and what the patient believes. And he said he did that test where he pushed down and I squeezed my muscle. And I can go to this book and look up the Clark sign and kind of show this patient, well, I don't base diagnosing on that test, and here's why. There is poor evidence or no evidence to suggest that test is telling anything important to us in terms of diagnosis. Now, do I do this for every patient? Of course not. But if I think it's going to help my cause, and my cause is to help this patient get out of pain and back to function as soon as possible, but in order to do that, I need to have the patient do what I asked him to do, and therefore I want him to believe that I know what's best for him and I know what I'm doing. In this case, I remember prescribing lumbar extension after investigation and the examination, and he came back better, and then I think he fell off after visit number 2 or 3, which a lot of people do, and I tend to find out later they were fine. But I don't know. I would never put that in research because that's just a guess anecdotally. He could have also been worse or exactly the same. But he tended to hold on to this belief that he had a chondral problem, which was also, I think, mildly apparent on the X-ray or MRI that he had. I forget exactly which image he used or how supportive it was of that thesis. But again, what I saw in the clinic was that if we moved his back, his squat got better, his knee signs and symptoms got better. So this can be used in the clinic to help patients understand why you're using the test that you're using. Unfortunately, we can only point to, it looks at repeated movement testing for centralization in the case of discogenic lumbar symptoms, but this test holds water for all manner of problems in the lumbar spine. I've had clinicians tell me, I had a positive blah, blah, blah test. And I'll look it up and say, look, that test was based on nothing. And of course, you can always look at the references and go study those studies for yourself. But that's what Cook and Hegedus, I'm assuming, spent a lot of time doing, is really examining the literature. So if you're a patient and you're struggling with symptoms, or you're a clinician who's struggling to help patients, then check this book out and see, what is actually there in terms of evidence for what you're doing. The 5 textbooks by Robin McKenzie and Stephen May can teach you how to use repeated movement testing of the spine and the extremities. They're great resources. Patients can learn by buying Treat Your Own Back or Treat Your Own Neck, etc. But unfortunately, I see this corollary in other realms of medicine. Does the literature actually support the guidance that we've been given about cholesterol, for example? When you take a deep dive into LDL, the evidence is not as sound as we've been told for decades, for example. I think the tide is starting to turn in terms of people who are struggling with health disorders, especially realizing that a lot of the evidence we've been given has been not necessarily intentionally misleading, but has been misleading. And some of it is because research is poor, study design is poor, the interpretation and the understanding of how to really read a study is poor. That's why I believe, now that I've been doing orthopedics for so long, that I can pick apart a study in my field if it's pick-apartable, because I really understand musculoskeletal systems or the musculoskeletal system, but I don't have that ability, for example, to pick apart a study on curcumin or to pick apart a study on other facets of medicine. I can read them, and I can read them better than the lay person, but it takes knowledge, especially I would say quite advanced knowledge about a field, to really know if a study holds any water. Like I've said before, you can make a study say whatever you want. If I believe that the positions that you're musculoskeletal system is in on a daily basis often, if not in the large majority of the cases, matter in terms of musculoskeletal disorders appearing. But if I wanted to prove to you that posture, meaning how your joints are when you're in positions for 6, 8, 10 hours per day, if I want to make a claim that posture is irrelevant, I would probably do a study where I looked at 18-year-olds, I would look at people who have no symptoms, I would look at people who are 18 who are also quite active, so they may be sitting for 10 hours in one position, but they're also spending 1 to 3 hours moving in other positions, for example, and I would make this study length maybe 6 months or a year. If I wanted to prove that musculoskeletal care and presence of symptoms and signs is related to the position of joints over time, I would look at a large cohort of people. If I wanted to be cherry picking, I would take people probably in their 30s and 40s and 50s. I would pick a cohort of people who are in that posture for 8, 10 hours per day and not also active, maybe people who have comorbidities, and I would study them for 15 or 20 years, which is obviously not going to be done. And I would look for that association between your lumbar spine or your lower cervical spine is in flexion for 10 hours per day, and therefore, blah, 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 you have symptoms 10, 15 years later. And I would also be inclusive. In the former example, I would just look for low back pain or neck pain. But here I'd be inclusive and being, well, we just talked about how joints in the spine can refer symptoms, they can create radicular symptoms, and in my book, they can also create mechanical problems kind of downstream, if you will. In this second example of a study, I would look at people's neck posture and not just the advent of neck pain or stiffness, but also headaches, jaw pain, shoulder blade, all the way down to the fingers, numbness and tingling included. I would look at the large possibilities of pathologies that could be created from the neck joints being in a certain position for 8+ hours per day and never moving in the other direction. Research needs to get better. Hopefully, I have other feelings about the research that we're doing in orthopedics, but hopefully more people will catch on that, hey, if repeated movement testing for centralization is one of 2 studies in the lumbar spine out of 32 that actually has strong support, well, why aren't we also using it for the neck? Why aren't we also using it for the thoracic spine and not just looking at centralization for radicular symptoms, but also looking for centralization or abolishing referred symptoms? So get this book, take a look at it. You don't have to sit down and read it all the way through. It's not kind of a text like that. It's more of a text where, like, if you want to just review the knee, go to the knee chapter, or if you want to look up a certain test that you want to use that day, you can look up that certain test. But this is such an invaluable test, and I think it provides support for schools, not just doctoral physical therapy programs, but other programs, other types of clinicians. Schools should be teaching at least repeated movement testing for centralization. If not in those other areas, they should at least be doing that because of the strong support of that test with the evidence. Feel free to leave some questions and I'll do my best to answer.